My name's Jeff Maltretter. I'm with the Neighborhood Pharmacy Association, and it's my very great pleasure today to introduce our speaker, T. Din. I've known T for at least the past 3 years or more. It seems like more than that. We've worked together on the Canadian Alliance for Sustainable Healthcare, which is one of the research centers within the Conference Board of Canada, and a number of research projects that T has done for ourselves, and we've had opportunities to collaborate on a number of different research initiatives. And I've always been struck by T's quick mind and her enthusiasm for pharmacy. I think it's really nice to find a researcher that is enthusiastic about the role of pharmacist and the role of pharmacy within the healthcare sector. So T. Din is the Director of Health Economics within the Public Policy Division at Conference Board of Canada. The majority of her research falls under the Canadian Alliance for Sustainable Healthcare, which our association is a member of. At the Conference Board, T has led the research on the health and economic impact of interprofessional primary care teams and the health economics of healthy active living. T has a Master's of Science in Epidemiology from Queen's University and a PhD in Population Health from the University of Ottawa. And it's my very great pleasure to welcome T to the stage.
Thank you, Jeff. I definitely do have a passion for the work that we've been doing on pharmacy services. And part of that, it connects back to, I think many of you are familiar with triple aim. When we think about population health, lower costs, and better patient experience. And now we're talking about quadruple aim, which is provider experience as well. So the work that we do in our pharmacy, in the pharmacy realm, really speaks to sort of the quadruple aim, and it contributes to health system sustainability, which I'll speak a little bit more to when I talk through the content on the value of pharmacy services. So I'm hoping to tackle a couple of big issues, and one of which is the work that we've been doing on value of pharmacy, looking at pharmacy as a contributor to the economy, but also in terms of its contribution to population health and improving access to services. I'll also be speaking to the issues or debate around Pharma Care and what it means for pharmacy and pharmacists. And then I'm hoping that we'll have adequate time at the end also to have a lively discussion on any of the issues that I'll be bringing up, and also very curious in terms of your perspectives, especially around the Pharma Care debate, that being a very hot topic today. So there are a lot of numbers on here, but I think the take home in terms of the economic footprint, and when we talk about economic footprint of an industry or of a sector at the Conference Board, we're predominantly looking at it from an employer perspective, the number of jobs and the economic activity that particular industry or sector is contributing to the economy. So we did a recent analysis for 2016. So the numbers you see are for the year 2016, leveraging data from Statistics Canada and employing our own input-output model of the economy at the Conference Board. And what we estimated was that in total, the pharmacy sector, the community pharmacy sector contributes about $16.1 billion to the economy in gross domestic product, and over 247,000 jobs directly and indirectly. So when we talk about directly, it's specifically the number of jobs that a pharmacy would employ. That includes pharmacists, that includes pharmacy aides and technicians, it includes tellers and shelving staff, for example. But the indirect employment are those other organizations, sectors, employers that contribute to the full supply chain. So that includes businesses that might support the activity of a pharmacy. So that would include other manufacturers, distributors, et cetera. Another important takeaway in terms of the economic footprint of the community pharmacy sector is that in comparison to other industries, it is significant, and maybe perhaps doesn't get as much attention as some of these other industries. For example, motor vehicle manufacturing. It is only slightly less in terms of contributor in terms of GDP. So you'll see there, and hopefully it's not too small for you, but certainly a lot of this information will come out in a release that'll come out shortly that compares the pharmacy sector to other industries when we think about it from an economic perspective. And that's just on the employment side. So, of course, there are other contributions from by community pharmacy when it comes to health and improving access to Canadians for services that they'll need. And when we think about right care at the right time by the right person, certainly pharmacy provides those services and contributes to sustainable health care by providing that kind of access, ensuring Canadians get the medical necessary medicines that they need, but they're also prescribed the right drugs, that they're using them correctly, that they aren't experiencing adverse events. So there are definitely many benefits from population and individual health perspective that pharmacies and pharmacists provide. So I've already mentioned the value of services in a pharmacy, community pharmacy, when it relates to the triple aim. When we think about lower per capita costs, Conference Board has also conducted research around the value of community pharmacy from a cost-benefit perspective. We did some return on investment analyses on several services and looking specifically at expanded services in a number of provinces. And the what-if question was, what if we had this service or expanded or scaled this service across the country? So we looked at services such as pneumococcal vaccination. We looked at advanced medication management for cardiovascular disease and smoking cessation, which includes, of course, the service of prescribing certain medications. And we found for all services there was a return on investment for the public payer. And what was surprising is even looking at pneumococcal vaccination, for example, which might not be accessed by significant number of people because we looked at only seniors who would have an indication for that for vaccination for pneumonia. It had the highest return on investment. So it's not about particularly having as many people as possible getting that service, but what is the biggest bang for buck when we think about if someone has pneumonia, they have a high cost to the healthcare system. Pneumonia is very costly from a hospitalization perspective. I think it was $11 for every $1 invested in pharmacy to provide expanded services in terms of pneumococcal vaccination, and the rest were definitely a positive return on investment. As we move forward also, we're looking at additional analyses in the value of community pharmacy work that we're working with Neighborhood Pharmacy on and the Canadian Pharmacists Association. And these include valuing core dispensing, which there isn't a lot of information on, but we're attempting to do some work on that. So stay tuned for when that gets released, I think later this spring. And we're also going to do some more work around minor ailments, prescribing, and expanding the work on the vaccinations piece. But happy to hear sort of your thoughts if you have any on what are some essential services that needs that kind of evidence and information. And I think it's also important to talk through why pharmacy has been so successful in addressing those triple aim issues, and why also the public payer has gravitated towards or being open to supporting these services from a reimbursement perspective. Pharmacists are considered trusted health professionals in the community. There's an ample amount of research that shows that patients they trust their pharmacists. They are also very loyal to their pharmacist. And so there are a lot of opportunities there. And I think early wins from a community pharmacy perspective are the successful, not experimentation, but experiences on the vaccination front. So if you talk to a public payer, so when I talk about public payer, that means provincial governments, that they've been very happy in terms of expanding those types of programs. So there's certainly a lot of opportunity, but it's always in conflict with the cost. And they'll always say, well, our drug budgets are very large. How can we afford this? So that being able to articulate the value of community pharmacy from a savings of the healthcare system perspective, improving access, reaching public health targets. Those are ways in which we can articulate the value of community pharmacy so that the payer, from a public and private perspective, can see that value and then support it from a reimbursement perspective. I probably went a little bit far on that, but certainly that's where we're coming from. Now I'm trying to segue into Pharma Care, which is definitely a hot topic. Some of the issues around Pharma Care is, what does it mean? We know there's something happening right now. For those of us from Ontario, we know the now former Health Minister, Eric Hoskins, is now heading up the Advisory Council for the federal government to look at what a national Pharma Care program would look like. And there hasn't been anything definitive on what that would be. The main question is, what do we mean by Pharma Care? It can mean many different things. It's been defined many different ways. From the academic perspective, we've heard a lot around universal Pharma Care, and it's been very much a push towards a one-payer model where the government pays, the government administers. There's a formulary for which, no matter where you live in Canada, that you're going to have access to these certain drugs with no cost, no out-of-pocket burden. Whereas we're starting to hear sort of, there could be other models. What does it mean if we choose a particular model of Pharma Care from a payer perspective, in terms of the public, private insurers, from the individuals? What does it mean for pharmacy? What does it mean for the pharmaceutical industry and the private insurance industry, which is a very large sector in Canada as well? And then what we also hear a lot about is Pharma Care could be a catastrophic plan versus universal. So do we understand what those mean? Right now, there are all provinces have a catastrophic Pharma Care program, which is that if you have an economic burden or financial strain to pay for your drugs, then there is a public program available that you could access. Whereas universal is that there is no out-of-pocket burden to you to access a certain types or number of drugs, depending on your demographic characteristics, for example. So part of the Pharma Care debate, again, is really understanding the elements of what the program is going to look like. So there are questions around who pays, what's being covered, so that's a formulary question under these programs. Who's going to administer? So the government could pay for it, but someone, private sector could administer it, or the public sector could pay and administer a program. Is it affordable? And from what perspective? So we talk a lot about affordability from the individual perspective, so for each patient. And I think for many, one of the core principles for Pharma Care might be that a Canadian should not have to pay $1 out of pocket for any particular drug or a particular set of drugs. But then what does it mean in terms of affordability for the public payer if the federal government or the provincial or federal government is going to pay? What does it mean for employers if we continue to leverage the private insurance market? So affordability has to be defined. It is also related to willingness to pay. So for those of you who are familiar with sort of the cost, the health economics or health economic evaluation on drugs, for example, that willingness to pay is arbitrarily set at a particular threshold, but willingness to pay thresholds differ by individuals, differ by payers. So there's a lot of work that needs to be done on that front as well. And so another question is, if we look at a national Pharma Care program that is potentially universal, paid by the government, what does it mean for the existing provincial programs? As I'll get into, there are many different programs across each province, and they vary in terms of design, in terms of eligibility, and the types of drugs that are covered, and also things like co-pays and deductibles and premiums, for example. So what does it mean for the existing infrastructure? But this is all hinged upon sort of a broader question around healthcare spending. And we know drugs is one of three major cost drivers of public healthcare spending. Their drugs, their hospital costs, and their physician costs or healthcare provider costs, which of course physicians contribute the largest share. And if we start looking at, and I think something came out recently by Andre Picard, looking at how Canada percent of GDP paid on healthcare, that we aren't actually paying a whole lot compared to our comparable countries in the OECD. But that's sort of a result of several years of cost cutting. And at some point, what we're seeing is a growth in healthcare spending, largely driven by the aging population. So we can't negate the fact that it's going to be stable anytime soon. And if national pharma care is going to happen, what are those costs going to look like moving forward with the aging population and increasing costs for hospitals and healthcare providers? If we also look at our comparator OECD countries, we also know the way in which drugs are being paid for is different. Canada is only one of a handful of countries that actually have a large mix of out-of-pocket spending by individuals, payment by private insurers for drugs, and by government. And it's almost a 30-30-30 split in terms of overall spending by those different types. And so, of course, if I talk to a private insurer, their concern is that, well, if we talk about universal or national pharma care, are we going to look like a country where there is no private insurer at all? And then there are those that say, no, there's always going to be a role for private insurers. It's going to be complementary. But again, these are questions that we don't really know what's going to happen if we don't start looking at the very specific design elements of what a pharma care or a pharmaceutical strategy might look like. I mentioned again that in terms of our current publicly funded pharmaceutical reimbursement or payment programs, they differ by province. The terminology patchwork has been used oftentimes, and it's very complicated. We spent almost a good year looking at all the different public programs, the design of each, and who might be falling under the gap. We know, I mentioned before, that catastrophic pharma care is there across the country. Universal pharma care is not. But we also know that there are pockets of the population that if they need a certain medication that's within the provincial formulary, that there are folks who do not have to pay out of pocket. And it's usually seniors or those who are on social assistance, very low income, and specific population groups. So, for example, those who might require cancer treatment and certain other disease groups. We know also, based on the research that we've been doing and sort of observing what's happening in the pharma care space, is that there are currently now options being put on the table. But the most, I guess, the option on the table that's getting the most traction seems to be that one-payer universal pharma care model. But what that would look like is very uncertain in terms of what's the minimum formulary. And I'm not sure if many of you have read or are familiar with the Parliamentary Budget Office report that came out in 2017 that costed out a potential national pharma care program. The estimate that would cost an additional $20 billion or so by the federal government, and essentially a lot of it would replace private insurance if we were to instill a formulary that's similar to Quebec. Formulary. And there are a lot of assumptions in that as well. I'd encourage you to read it. It's a long report, but some of the assumptions that, I think that were part of that assessment may not necessarily be something that would be a characteristic or a design element of a pharma care program. That includes negotiating lower costs, which we know is happening already, or prices rather, for generics. Ensuring that there are no excessive costs or pricing, for brand name drugs. These are things that are happening already that aren't necessarily part of a pharma care program. So the question is, a true pharma care program, how does what's the true cost of it? What are the cost savings versus what's happening today in terms of the cost-cutting measures that are already happening? And can we really understand sort of the true cost of a new program, and what elements of the design of that Pharma Care program is going to have the most impact in terms of access? So those are some of the questions that we're assessing from a Pharma Care perspective. A little bit more in terms of looking at that mix of the public and private plans. If you are interested in looking at a report, it's called Understanding the Gap, Pan-Canadian Analysis of Prescription Drug Coverage in Canada. We noted that there was actually a very low level of uninsurance. Uninsurance means, are there people who have no access to coverage at all? That includes private and public. So we're looking at eligibility as opposed to enrollment or accessing a certain program. And so as of January 1st, when OHIP Plus came into effect, the actual percent or proportion of the population that was uninsured, we estimate was actually less than 2%, was 1.8%, which actually would represent folks in Ontario and Newfoundland, and representing, for example, children and youth, those who are precariously employed, who do not have access to private insurance through their employer, or who have not reached an income threshold that would allow them access to a public plan, and who do not have private insurance. We also estimated there are actually about 4 million Canadians or so who are eligible for a public plan in their province, but do not access that plan. So they don't actively enroll in it or submit claims to get reimbursed. And there could be a number of different reasons. And the reasons, we would call them as underinsurance. This could mean that they need a drug that might not be on the formulary. They might not be able to pay into the public program because some of these public programs have a copay or a deductible or a premium that they have to pay into. Or it could be that they don't need the coverage at all. So there are a lot of different reasons, but it's hard to quantify those without really defining what is an access issue. And what we'd like to do is do some further research to uncover or better understand what the underinsurance means. And that will also allow us to look at, well, if we were to look at the existing infrastructure of public programs, what could be done to improve those public programs so that that we could fill the gap, essentially, from an underinsurance perspective. So I mentioned, again, we want to uncover why the 4 million or so who have access aren't accessing those programs, or who are eligible, rather, and why. And we might want to look at the out-of-pocket costs and the affordability issues with having to access those programs, as well as the formulary issues that might be there as well. I mentioned again that there are very key elements of a national Pharma Care program that we need to be able to uncover. And there are some very specific questions that we need to ask that I mentioned before: who pays, who administers, what's included, et cetera. But there are some very specific design issues as well, as I mentioned, as we looked at the public plans that are currently in place in each of the provinces. That includes, what's the out-of-pocket spending? What is the burden, financial burden on the individuals? What's the financial burden on the public payer or the private payer? There is also a need to understand, in terms of affordability, whether cost is a factor in why Canadians may not be accessing certain drugs, or filling their prescriptions, or not being compliant. Part of the research that we did included a survey that Nanos undertook for this project, and they asked a lot of different questions. One of the questions, though, was asking, if you had a prescription in the last 12 months, what were the did you comply with your prescription, or did you fill your prescription? And then they asked questions around, well, what were the factors that impacted whether or not they filled their prescription or were non-compliant, which is different from some of the other surveys that have been conducted to date. And a very small proportion of Canadians surveyed who didn't fill the prescription said that cost was a factor. What we uncovered also, what Nanos uncovered also, was that there was actually a significant number of people who weren't aware of public programs, because we wanted to understand also sort of literacy around what programs were available. So that kind of showed us as well is that there wasn't a clear understanding of what public programs were covering, eligibility criteria, access issues, or accessibility. And that was clear because, for us being in the health space, we didn't have a clear idea of what these programs looked like as well until we did this research. So some of the options that are being put on the table, and I'm only giving 3 scenarios, which I think are the ones that are on the table right now, but what I think are also likely to move forward on. And I think the likely to move forward on is, and I'll mention that at the end actually. So one scenario is always the status quo, which is right now there's a mix of public and private programs. There's variation in terms of what drugs are covered, eligibility criteria to be part of a public or private plan. And then the role of the federal government is that they cover some unique populations. They provide the health transfer funding to the provinces to help pay for some of the public programs. And they also regulate and approve drugs. We also know that there's an option to tweak the current system. So what we might say is look at how do we fill the gap. We know that there is a gap in terms of underinsurance and uninsurance based on the research conference board did. So how do we fill that gap by looking at the designs of each of these different programs and how we can improve upon those so that we can ensure more Canadians have access to the drugs they need at the right time, at the right cost. And then there's the other option on the table, which is a universal health care, pharma care plan paid by the government, administered by the government, which would have an impact on current public programs, would have an impact on the private insurer. It may be that there would still be private insurance, but they would have to provide either additional coverage for drugs that aren't on the formulary, or they would provide complementary programs, or maybe they would offset some of the out-of-pocket costs that the public programs might actually have part in terms of the design of those programs. What I think is probably more of a likely scenario is that it's going to be a minimum formulary that would be a universal pharma care program. There's going to be a set of drugs that the government will pay for and which all Canadians, no matter where they live, would be able to access at no or little cost. I think that's where it's going to go, but what those drugs will look like, whether it's going to be the Quebec plan, which is very comprehensive compared to other provinces, but less comprehensive than the private plans. So it really fundamentally goes down to what are the core principles of what pharmacare should be from different perspectives of all stakeholders that are impacted by a potential pharmacare program. That includes pharmacy as well. So if part of the principles is that Canadians shouldn't have to pay for a certain set of drugs, or is it that, I think one of the key principles should also be that no one should be less or just, worse off with a new program. So we have to ensure that someone who is enjoying maybe perhaps their private insurance plans right now, that they aren't losing out on something that was covered in their private insurance that now might not be covered under public insurance. So these are some key issues that we need to address. What is pharmacare, the pharmacare discussions, what does it mean for pharmacy? There has been very little discussion other than from the pharmacists themselves around ensuring that the impacts on pharmacy are part of the discussions around pharmacare. We haven't heard that a lot, but I think as we move forward and hoping that there's a voice for pharmacy and pharmacists at the table there. But I'm just leveraging some of the core principles out of the Canadian Pharmacists Association for pharmacare. It's addressing the gaps between private and public systems. I've mentioned that before in terms of the opportunities moving forward, protecting Canadians from undue financial hardship, which I think is a principle for everybody when we talk about pharmacare. Protecting patient access to a stable supply of clinically and cost-effective drugs. I think, again, a common principle. And the fourth, in which I don't think is common, but which I know that the pharmacist and pharmacy sector wants to make sure that that's part of the discussion, is that we're providing access to the full range of services to achieve better health, better care, and better value. So it's not just providing funding or ensuring that there's access to drugs, but the services that go along to ensuring that it's the right drug at the right time, reduction of adverse events, ensuring compliance, et cetera. So if there is a movement towards a public-funded one-payer system, there will be an economic impact for pharmacy, likely a reduction in terms of profits. So definitely pharmacy needs to be at the table in all discussions around Pharma Care. The opportunity is now, knowing that there is an advisory council being developed and overseen by the federal government. And certainly, there is a need to have pharmacy at the table when we start looking at the core principles of what a Pharma Care program should look like. So with that in mind, that'll help sort of decide or help build sort of a design platform or framework for a Pharma Care program moving forward. But it's not going to happen overnight. It'll take at least a year for them to just get to a plan of what the principles might be. What would be covered. So implementation is going to take a while, but now is the time to sort of get those ideas there and ensure that the right people are at the table. So thank you for that. I hope I didn't go over too much time. Jeff, any questions?
Time for questions. If anybody has any questions for T?
Yes. Oh, go ahead. Hi.
Just on the Pharma Care question, I think a lot of folks that are pushing the universal model are doing it from a cost perspective as opposed to an access perspective. What are your thoughts in terms of the estimates currently being put there in terms of how that model might reduce costs to the overall?
Yeah, no, exactly. And I think it's worth scrutinizing some of that cost assessment. Because again, if we look even at the PBO report and even what some of our academic friends have produced, that some of these assumptions around cost are things that are already happening outside of Pharma Care, which is renegotiating pricing, for example. And even with the PBO report, there's an assumption that you're getting the lowest cost plus a reduction, another discount at 25%. So I think it's worth looking at the costing if they're really accurate. And there are other assumptions in terms of, and if you look at some of the assumptions out of the PBO assessment, is that they're not taking into account the rise in the cost, not the cost, but utilization of specialty medicines. So we think about biologics and the high-cost drugs. They kept that stable, but we know that's going to go up. So I think it's an underestimate of the cost for our National Pharma Care program, but it definitely is sensitive. So the cost will be sensitive to what's on the formulary. What are we going to cover in terms of universal access for these types of drugs moving forward? So that's on the costing side. Whether it's affordable, that's another question, because right now they're saying overall costs are going to go down, but someone still needs to pay for it. So when they say the costs will go down for the employer who may be paying into these private insurance programs, it's going to go down for individuals, but it's going to go up for the public, for the public budget. So overall cost savings, yes, I can see that, but it's going to increase the cost for the public sector. And is it affordable when we think about all the other social programs that we also need to pay for with an aging population? That includes home and community care, mental health. It also includes, when I think about it, I have a almost 12-month-old childcare and how unaffordable that is. So there are a lot of social issues and costs, and that I think when they're looking at Pharma Care, whether it's affordable, when you think about the full budget of what a provincial program or a federal program might have to pay for, that's a challenge. There was another part of that question you had, Glenn, that I don't think I answered. I did? Okay. Yeah, and I think because that's on the table, I think we haven't looked at other options, and I know Canadian Pharmacists Association had PDCI do some assessments on particular options as well, and I would say we should look at the extreme options, but we need to look at other options in between as well to say, well, what is going to get us the best value when we think about access? Yes, it's the access question. There's a lot of talk around costs, But if we talk about principles in terms of timely access, there have been some debates, and I would say that, pharmaceutical industry might say that, if we drive costs down, we might take longer to have access to certain drugs. So I wouldn't throw that argumentation out, but evaluate, is there going to be an issue in terms of accessing innovative medicines if we talk about only a universal pharma care program for existing drugs today?
Maybe you could comment a little bit on the plans that Conference Board has to investigate this issue of pharmacare further.
Yeah. No, I think we're going to do something in the spring, summer, starting to, at least on the engagement side, get all the stakeholders together, including pharmacy, but the public, government, getting the insurance, private and public insurance, and patients at the table to understand. We'll try to get to some consensus around the principles, because we have to start there, and also understanding what's the current system that we have today. I don't think many people really understood about that patchwork of public programs. Is it a matter of filling the gap, or is it around what should national pharma care look like? So we're starting a discourse, and we're hoping to hold that around early summer, late spring. But we'll also look at doing some additional research, which is to filling the gap research, and costing out specific pharmacare options. And that includes also looking at that universal pharmacare proposition that's out there right now, taking a closer look at the PBO report, and ensuring that the costing is sound. At the Conference Board, we have over 30 economists. So what we want to do is take an economic lens to it, but we also want to be able to ensure that we're putting that, the affordability, looking at willingness to pay, timely access, all those other core principles that will come out of that discourse or engagement process that we hope to start over in the summer. If you're interested in learning more, feel free to, I'm happy to talk about it, or you can email me. It's a little bit early days, but we're starting to get that work underway very shortly. Yes.
Can you comment on the potential implications to the amendment, from the amendments to the patented medicine regulations, and the way that those changes might work their way into pharmacare?
The PMPRB work, yeah. So they've gone through this process of modernizing their framework, and they're looking at, and I think their purview is really not so much around the pharmacare piece, but controlling costs. So we think about it just from a cost perspective, because they say, okay, we don't want to go out of our scope, but they're kind of reaching a little bit out of their scope from traditional. They're looking at what is an appropriate threshold for a price on particular medicines. So that plays into pharmacare in the sense that, well, we're going to see lower costs for drugs, but if we talk about pharmacare, it's really access to drugs at the end of the day. So there is an impact in terms of overall costs and spending on drugs with what PMPRB is doing, but we have to also separate it from what pharmacare looks like, which is a plan to have access to pay for these drugs. So they're complementary, but what PMPRB does, their mandate isn't around pharmacare. It's going to be, I think, Health Canada, but we'll see what happens with the advisory council, because I don't know if anything has come out recently, but sort of the plans in terms of how that's being rolled out, what their terms of reference are, who's going to be on that council, we'll have a better idea, I think. I don't know if I can flip it on to maybe to the audience even, in terms of their thoughts on the pharmacare, or if you think I'm off base in terms of what we might be moving towards, because I think whether we think it's good or not, some type of pharmacare is going to happen. Do you think it's going to be tweaking at the margins, or do you think it's going to be a minimum formulary? I don't know if you have any ideas from your perspective.
Well, maybe show of hands. How many people think there's a good chance that the single payer concept will get implemented? Does that seem likely or unlikely? I I'm seeing some shaking heads here. People don't believe in that. So then is the alternative more filling the gap and bridging the coverage gaps that might exist today? I think.
Yeah?
I'm seeing a lot of nodding heads here, so that's interesting.
That's
from
what
our
Morneau
perspective.
said, 48 hours after the hospital.
Yeah.
And then you got hammered for it.
Yeah, exactly. So there's a pressure, and there might be actually a mix of the two, to be honest with you. Like I said, again, maybe there's going to be universal pharma care, but for essential medicines list or something or other, but I don't know.
Well, anyways, thank you very much, T.
Thank you.
That was terrific.